Hello, and welcome to the Chest Journal's Editor Highlights podcast. Each month, Chest Editor-in-Chief Dr. Peter Mazzone highlights key articles from the current issue of the journal to help clinicians stay informed about new research in the fields of pulmonary, critical care, and sleep medicine. To introduce this month's episode, here is Dr. Peter Mazzone.
Thank you for tuning in to the Editor's Highlight podcast for the April 2025 issue of the journal Chest. We have a great lineup of diverse content in this month's issue. Over the next 15 minutes or so, I'll provide a brief overview of key manuscripts published in each of our content areas. First is our asthma content area. Many patients with severe uncontrolled asthma do not have a complete response when receiving biologic therapy. In this issue, Cozio and colleagues report findings from a prospective multi-center study that included 92 consecutive patients with severe uncontrolled asthma who underwent bronchoscopy with bronchial biopsy prior to biologic therapy initiation. The study was designed to determine if bronchial biopsy could help to identify patients with severe uncontrolled asthma who have a better response to biologic therapy. The pathologic score, a previously validated tool, was independently associated with the response to treatment, whereas a score of type 2 inflammation was not. Super responders had a statistically significantly higher pathologic score. Low tissue eosinophilia was associated with a poor response. These findings suggest bronchial biopsy, particularly related to tissue eosinophilia, is a better predictor of response to biologic therapy than the T2 score. Completing this section is a euphoria consensus statement about promoting prevention and targeting remission of asthma. Next is our chest infections content area. European guidelines previously proposed an algorithm for the empiric treatment of nosocomial pneumonia. In this issue, Calabretta and colleagues report findings from a retrospective analysis of data collected from a prospective cohort of 315 patients with microbiologically confirmed pneumonia from 6 intensive care units at a single center. The study was designed to determine if these guideline recommendations were effective in reducing the incidence of adverse outcomes in ICU patients with nosocomial pneumonia. Overall outcomes were similar between groups with and without guideline adherence. In the subgroup without septic shock, treatment according to the guidelines led to reductions in both ICU mortality, 28.8% versus 14.5%, and adjusted 28-day mortality, hazard ratio of 3.07. No benefit was noted in those presenting with septic shock. These findings suggest that adherence to the guideline treatment algorithm may lead to reduced mortality in ICU patients with nosocomial pneumonia without septic shock at presentation. Completing this section is an original research article that explores the relationship between Aspergillus serology and clinical outcomes in patients with bronchiectasis from the European Bronchiectasis Registry. Our COPD content area is next. Alternative methods of pulmonary rehabilitation delivery may improve program access, but could affect the response to rehabilitation. In this issue, Cox and colleagues report findings from a secondary analysis of 2 randomized controlled trials totaling 266 individuals with COPD, designed to compare the rate of clinical response to home-based telerehab and that of center-based pulmonary rehab. The proportion of rehab responders was not different between the 2 delivery methods, either at the end of rehab or after 12 months of follow-up. Baseline outcome values, but not participant demographic characteristics, were most associated with responder status. The relative risk of program non-completion was higher in the center-based group. These findings suggest similar responder rates between center-based pulmonary rehab and home-based telerehab, without clear findings to guide the selection of setting for an individual person. Also in this section is an original research article that evaluates risk factors and clinical impact of severe pneumothorax after endoscopic lung volume reduction with endobronchial valves, and a research letter that evaluates physical capacity and physical activity as determinants of mortality in patients with COPD. Completing this section is a chest review of COPD-related expiratory central airway collapse and the Canadian Thoracic Society Clinical Practice Guideline on alpha-1 antitrypsin deficiency-targeted testing and augmentation therapy. Next is our critical care content area. The impact of albumin infusions in patients with septic shock who have kidney impairment is not known. In this issue, Patton-Walla and colleagues report findings from a retrospective, multi-center, inverse probability of treatment weighted cohort of almost 10,000 patients from 220 geographically diverse community and teaching hospitals in the United States. The study was designed to determine if the early use of albumin mitigates the need for renal replacement therapy or in-hospital mortality in patients with septic shock and kidney impairment. The composite outcomes of renal replacement therapy or in-hospital mortality occurred in 34% who weren't treated with albumin and 40% of those who were treated with albumin, an odds ratio of 1.29. The increase was more pronounced when 25% albumin was administered than with 5% albumin. These findings suggest that early albumin use may lead to increased need for renal replacement therapy or in-hospital mortality in patients with septic shock and kidney impairment at the time of hospital admission. Two other original research articles appear in this section. The first is a randomized multi-center study of the treatment of acute circulatory failure based on carbon dioxide and oxygen-derived indices. And the second is a systematic review and meta-analysis of prophylactic antibiotic use in adults with acute brain injury who are invasively ventilated in the intensive care unit. On to our diffuse lung disease content area. The effect of hypnotic use for insomnia on the clinical course of patients with idiopathic pulmonary fibrosis is unclear. In this issue, Mazzone and colleagues report findings from an evaluation of two hospital-based cohorts, one 99 patients, the other 123 patients, as well as over 30,000 patients with idiopathic pulmonary fibrosis from the National Database of Health Insurance Claims and Specific Health Checkups of Japan. The study was designed to determine if hypnotic use is associated with an increased risk of mortality in patients with idiopathic pulmonary fibrosis. In both the hospital-based cohorts, the continuous use of hypnotics was associated with increased risk of all-cause mortality, with hazard ratios in the 3 to 4 range. This finding was consistent regardless of sex and comorbidities. In a target trial emulation from the NDB cohort, the per-protocol analysis showed that hypnotics treatment was associated with increased mortality with a hazard ratio of 1.71. These findings suggest an association between the continuous use of hypnotics and increased risk of mortality in patients with idiopathic pulmonary fibrosis. Also in this section is an original research article evaluating practice patterns of sarcoidosis treatment in the United States from 2016 to 2022, and a chest review on the dawn of precision medicine in fibrotic interstitial lung disease. On to our education and clinical practice content area. The standard for evaluating expiratory airway function in infants is technically difficult and has a high failure rate. In this issue, Hevroni and colleagues report findings from an observational retrospective analysis of 296 infants who underwent pulmonary function testing using the raised volume rapid thoracoabdominal compression technique. The study was designed to determine if measurements obtained during passive expiration from total lung capacity correlate with forced expiration measurements obtained by the raised volume technique in infants. A technically acceptable passive flow volume curve was found in 93%, while 76% had acceptable forced flow volume curves. There was a higher success rate for producing acceptable passive curves. The Spearman correlation coefficients of vital capacity, expiratory volume at 0.5 seconds, maximal expiratory flow, and expiratory flow at 50%, 75%, and 85% of vital capacity ranged from 0.92 to 0.66. The mean intermaneuver coefficients of variation were 5.2% and 5.4%. These findings suggest that the passive flow volume curve offers reliable and reproducible data with high correlation to the forced flow volume curve. Completing this section is a chest review on lung nodules and masses in non-HIV immunocompromised patients. Our pulmonary vascular content area is next. The evidence regarding the role of beta blockers in the management of pulmonary arterial hypertension with or without comorbidity indications is unclear. In this issue, Walagora and colleagues report findings from a retrospective analysis of 806 patients with newly diagnosed pulmonary arterial hypertension who were enrolled prospectively in the database of PH in the Polish population. The study was designed to determine the effects of beta blocker use on clinical outcomes in patients with PAH and how these outcomes differ according to the presence of cardiovascular comorbidities. 58.2% of those enrolled received beta blockers at the time of PAH diagnosis. After propensity score matching, the composite endpoint of hospitalization due to right heart failure, syncope, or death was more likely to occur in those receiving beta blocker treatment, with a hazard ratio of 1.44. The hazard ratio was 1.22 for mortality alone, which did not quite meet statistical significance. Beta blockers showed an adverse impact on the composite endpoint in patients without comorbidities and had a neutral effect in those with at least one cardiac comorbidity. These findings suggest that beta blockers may pose a risk in patients with pulmonary arterial hypertension, particularly in those without coexisting hypertension, coronary artery disease, or arrhythmias. Also in this section is an original research article that evaluates the association between thrombus histopathology and hemodynamic outcomes among patients with chronic thromboembolic pulmonary hypertension who undergo pulmonary endarterectomy. Completing this section is a special features article, the Apollo Summary on Pulmonary Vascular Disease Fellowship Training. On to our sleep medicine content area. Many symptomatic individuals with central sleep apnea have an indication for adaptive servoventilation therapy. In this issue, Timissier and colleagues report findings from a prospective, multicenter, observational cohort study of 526 patients with predominant central sleep apnea or obstructive sleep apnea with central events who aren't controlled with CPAP. The study was designed to determine the effects of adaptive servoventilation on sleep quality and patient-reported outcome measures across a series of indications. The median change in the Pittsburgh Sleep Quality Index score from baseline to 6 months was -1 in the overall population, with significant results across all indications except for drug-induced central sleep apnea, which had a similar impact and did not reach statistical significance. Overall, 65% of participants showed a 1 point or greater improvement in the Pittsburgh Sleep Quality Index. These findings suggest that individuals with a clinical indication for adaptive servoventilation therapy experience improved sleep quality during real-world treatment. Next is our thoracic oncology content area. The length of follow-up required for pure ground glass nodules detected on low-dose CT imaging is unclear. In this issue, Kim and colleagues report findings from a retrospective cohort study that included 89 patients with 135 pure ground glass nodules, designed to determine the percentage of pure ground glass nodules that enlarge after 10 years of stability. They noted an increase in size in 23 of the nodules, 17%, with a median time to change of 71 months. The increase in size was noted within 5 years in 35% of those that grew, between 5 and 10 years in 52%, and after 10 years in 13%. In 76 pure ground glass nodules that were stable for 10 years, only 3 or 4% increased in size. These findings suggest a low rate of growth overall and a 4% chance of growth after 10 years of stability. Also in this section is an original research article on patterns and differences in lung cancer treatment in the United States from 2015 through 2020, and a How I Do It review on leveraging patient advocacy and faith-based partnerships to help educate, activate, and prepare Black communities to be screened for lung cancer. I encourage you to read our Humanities and Chest Medicine section, where you'll find an original research article on conflicts of interest in bronchoscopy research, as well as our commentary series, where you'll find thoughtful pieces about bronchodilator responsiveness, a test in search of indications, and the early diagnosis and treatment of COPD and asthma. Finally, please review our case series publications for the month, which provide novel and educational cases to help improve your clinical skills. I hope that you enjoy reading all of the high-quality content available in this month's issue of Chest. As always, I'm grateful to the authors of this work, reviewers who volunteered their time to improve the quality of these manuscripts, and to our editorial board for guiding everything that we do. Until next month, I hope you enjoy the April issue.
Thanks for listening to the Chest Journal's Editor Highlights podcast. You can find the articles mentioned in this podcast and more on chestjournal.org. And if you're looking for more context and commentary on articles in the current issue, please check out the original Chest Journal podcast, which features in-depth discussions with the authors themselves. We'll be back again with more Editor's Highlights next month.